Okay, so the activity of the local anesthetics, there are 3 points to keep in mind. Potency of the drug, onset of action, and duration of action. Now, potency essentially refers to how well the local anesthetic can cross the lipid bilayer. Now, in order to cross the lipid bilayer, it needs to be lipid soluble. So potency correlates with lipid solubility. Now, this has been true for in vitro experiments. However, in vivo, there are other things to keep in mind. For instance, patients have adipose, which is lipid, and can function as a sink for local anesthetics and decrease your local concentration. Local anesthetics also vasodilate, which decreases the volume of distribution. And lastly, the clinical application, what you're actually using the drug for, can affect the potency. So, a nice table from Barish showing peripheral nerve, spinal, epidural. Depending on which your clinical application is, the relative potency of your drug is going to change. You can see the variations for bupivacaine, whereas for lidocaine it tends to be relatively constant. So stereochemistry also plays a role. One of the key drugs is bupivacaine, which tends to be in a racemic form, R and S enantiomers. And there have been issues with cardiotoxicity with the R enantiomer of bupivacaine, which led to the production of levobupivacaine, which has been shown to have less cardiotoxicity. However, it is less potent. Ropivacaine is also comes in an optically pure form. You can get it in the S enantiomer, and it has less cardiotoxicity. There are different measures of potency. Common one is the minimum concentration. Okay, onset of action. So onset of action depends on the ratio of your uncharged weak acid local anesthetic to your charged form. So remember the graph I brought up before demonstrated the lower the pKa of the local anesthetic, the more of that local anesthetic is going to be in its uncharged form, which means that there's going to be a faster onset of action. Lastly, the duration of action, it has to do with plasma protein binding, which may be a surrogate for how well the local anesthetic binds to the active site of the sodium channel. So quick review: potency, lipid solubility, onset of action, ratio of uncharged base to charged base, and duration of action, plasma protein binding. Okay, so there are various additives you can use with your local anesthetics. There's 4 that we're going to talk about, starting with epinephrine. Epinephrine is a vasoconstrictor, which will help decrease the systemic absorption of local anesthetic. This in turn allows the local anesthetic to bathe the nerve for a longer period of time, which will prolong the block and make the block more intense. Now remember that local anesthetics actually function as vasodilators, so epinephrine helps counteract that. Now you can only use small doses of epinephrine, and this is because the vasoconstriction, if too intense, may lead to skin necrosis. Also, there's associated cardiotoxicities. Epinephrine can be arrhythmogenic, and also there are associated toxicities with peripheral nerve and spinal cord. Base, sodium bicarb, can be used to assist with your local anesthetic. Remember that local anesthetics come from pharmaceutical companies, often packaged in acidic solution, especially if epinephrine is present, as epinephrine needs a low pH as low as 4 or 5 to remain stable. When the pH is so low, you can have as little as 3% of your local anesthetic in the uncharged form. And remember, you need your uncharged local anesthetic to cross the lipid bilayer. So sodium bicarb can be used to help alkalize your local anesthetic solution and help increase the onset of action of your block. However, there is a limit to how much base you can add due to the risk of precipitation. So the benefits of adding base to your solution are a faster onset of block. However, some studies have shown that adding base may decrease your duration of block. However, this is not true if there's epinephrine in your solution also. So opioids can also be used with your local anesthetic. For neuraxial blocks, there is synergy with your local anesthetics, and it's thought that this is due to opioids inhibiting nociception at the C fibers. One notable exception is 2-chloroprocaine, which when combined with opioids may actually decrease the effectiveness of opioids. So alpha-2 adrenergic agonists can be added to your local anesthetic. For neuraxial and supraspinal anesthetics, you can attain analgesia via the action at the alpha-2 receptors. And for peripheral nerve blocks, alpha-2 adrenergic agonists will actually inhibit peripheral nerve conduction. Now, a good example of one of these drugs would be clonidine, which can inhibit the action at A and C fibers. And drugs such as clonidine have really been shown to improve anesthesia for neuraxial blocks, for peripheral nerve blocks, and for intravenous regional anesthesia. So the pharmacokinetics of local anesthetics, 3 main points to keep in mind: the systemic absorption, distribution, and elimination. So for systemic absorption, we want to give enough local anesthetic so that we can safely achieve our block without having too much absorbed that we have plasma levels that are toxic. So the dose of local that you use can affect your absorption. Also, the concentration will affect absorption, and that using low concentrations can cause vasoconstriction, so there's less absorption. And when you use higher concentrations, there's actually some vasodilation. Also, the lipid solubility of your drug is important, as drugs that are more lipid soluble have a slower rate of absorption. Epinephrine causes vasoconstriction, so there is less absorption. And site of injection is also important. There are multiple sites that local anesthetics can be injected, and depending where the injection is, there are different plasma levels, peak plasma levels. So intravenous injections will cause the highest peak plasma level. This can be intentional, or in cases of toxicity, this can be an inadvertent intravenous injection. Also going down the list, tracheal will be your next highest, then intercostal, caudal, paracervical, epidural, brachial plexus, sciatic, and lastly subcutaneous will give you the lowest systemic absorption. So distribution of the drug is important. Different drugs have different steady states for volume of distribution. When you do achieve a steady state for volume distribution, the concentrations of drug in different compartments are different, and this is due to differential perfusion of parts of the body. 2 highly perfused organs are the heart and the brain, which can receive high levels of local anesthetic, and this is also an issue as the sites of toxicity tend to be in the heart and the brain. So now we have our drug in the body, it's time to eliminate it. The method of elimination depends on whether we have an ester or an amide. So starting with the esters, these drugs are hydrolyzed by plasma esterases, otherwise known as pseudocholinesterases. This elimination is rapid. It generates water-soluble products which are eliminated in the urine. One of the products is para-aminobenzoic acid, otherwise known as PABA. There's a picture of it over here on the right. Some patients have allergy to local anesthetics, usually it's to the esters, and it's thought that it's to this PABA component, this metabolite. A few things to keep in mind about pseudocholinesterase. For intrathecal injections, such as your spinal anesthesia, CSF doesn't actually contain pseudocholinesterase. So in order to metabolize your ester, the local anesthetic will be absorbed into the bloodstream, and then when circulating through the bloodstream, it will be metabolized. Secondly, patients have genetic variations in their pseudocholinesterase, and some may not metabolize as quickly as others. Cocaine is one special exception. It is an ester. However, it is metabolized like an amide in the liver, and some cocaine is actually excreted unmetabolized in the urine. So now for the amides. These are metabolized in the liver by the P450s. few things to keep in mind. Some patients will have liver disease, such as cirrhosis, and these patients will not metabolize amide local anesthetics as well as healthier patients. Also, consider blood flow to the liver. Conditions such as CHF may decrease hepatic perfusion and therefore elimination of amides. So as for rates of elimination of amides, it really depends on the drug, but one thing to keep in mind is that it's much slower than the rapid elimination of the esters. Metabolites of amide elimination are cleared by the kidney, and unlike esters, there are no allergenic substances. So two of the amide anesthetics, when metabolized, their metabolites may cause methemoglobinemia. So Lidocaine, when given in large doses in epidurals, may lead to methemoglobin formation in the neonate. Also, patients with impaired heart and lung function may have methemoglobinemia from Lidocaine. Benzocaine, used in oral sprays, has also been shown to sometimes cause methemoglobinemia. And of course, the treatment for this is IV methylene blue. So briefly, we'll talk about the clinical applications of local anesthetics. It can be used for regional anesthesia, central techniques such as epidurals and spinals. If you want to go more peripheral, we're talking intravenous, peripheral nerve blocks, topical such as Emla cream, oral benzocaine spray. Different options for delivery. You can use a single shot or you can put in a catheter for a continuous infusion. Really many options here. Lidocaine can be used to stop ventricular arrhythmias or also for local anesthesia. Some of the benefits of lidocaine is it can decrease responsiveness of the airway to instrumentation, mostly intubation and extubation. It can help blunt the hemodynamic response during these procedures, decrease coughing, bronchoconstriction, and also keep in mind that lidocaine can help decrease intraocular pressure, intracranial pressure, and intra-abdominal pressure. So why might you care about this? Say you have a patient with a corneal laceration, patient has brain tumor, for whatever reason you want to keep the pressures down, you can use lidocaine with your anesthetic while intubating and extubating.